I have a whole panel comprising the entire geriatric clinic from TMH here. Most of us know all of them. We also have Dr. Tarachand, who's accepted to be part of the panel. And other than him, we have Dr. Sharath, Dr. Sarika, Dr. Anita, Dr. Akhil, Dr. Sridhar, Dr. Abhijit, and Ratan, who are the base of our entire geriatric clinic. We have online Dr. Lekika and Dr. Sharda as well. So we'll start with a case as usual. This is a 63-year-old gentleman who has a history of smoking, history of diabetes, coronary artery disease, possible asthma, and he has lung cancer, since that's the theme of the meet. It is stage 4 disease. He has no actionable mutations and he's not feasible for immunotherapy, to keep it simple. His PS is 1, hemogram is okay, creat is 1.3, albumin is 3.1. He was seen in the clinic and planned for chemo plus zoledronic acid. So my first question is, I'll ask this first to one of the oncologists. Dr. Akhil, would you consider this patient as an elderly patient or not, and why?
So in our country, we consider this age to be geriatric age. As we have discussed this multiple times previously as well, in all our guidelines, government guidelines, more than 60 is considered to be a retirement age. Everything is designed like that way. So we consider this to be an elderly patient.
I agree with you. I'll take the opinion of one of our geriatricians, Dr. Anita. What do you think? Most of the data across the world says 65, some say even 70. For example, for colorectal cancers, elderly is 70 years. So this is a decade earlier. What do you think?
But I think the life expectancy in the Indian population is lower than the other population that you compare. So therefore, you would take the elderly population at a slightly earlier age, which is 60, rather than 65, which is as per WHO standards.
Agreed, because in Japan, the average life expectancy is 80, and in some places it's 100. In Okinawa, if I'm not wrong, and India, it's still 68 to 70. So, I think, and as Akhil pointed out, 60 is what our government says, and I think we should stick to that. Fair enough. Now, okay, so we agree that this patient is an elderly patient. So my next question to one of the oncologists is, and Tarachand, you can take that. Will you do a CGA in him? Assuming you're in a busy private or government hospital, will you consider him for a CGA?
Yes, I will consider him for the CGA. And before that, I can do it GAT scale as we have discussed in the last slides. But yes, on grossly looking, it is seen that it may be a score maybe less than 14. So we can go upfront for the CGA.
Okay, I'll take one more opinion on that. Dr. Sharda, can you hear me?
Yes, sir, I can hear you. Okay. Can you hear me?
Yeah, clear. So based on the available information till now, will you do a CGA in this patient?
I would like to do a screening first, probably, and then go ahead with the complete geriatric assessment. As of now, where I work, I don't have access to geriatric onco clinic yet. But theoretically, yes, I would like him to go for a comprehensive geriatric assessment.
Yeah, okay.
So, sir, we have now started geriatric clinic at our hospital at TMH Varanasi. We see 600 patients in medical oncology OPD daily. If and at least 150 patients are of geriatric age. So this is the problem. If we do geriatric CGA for 150 patients, it will go till next day. So that will not be feasible. So I completely agree with Sharda ma'am's comment that we should take some part of screening. And as we in our geriatric oncology group, we are trying to develop a short assessment scale. We have already started following that at our clinic, and the patients, those domains where they are deficient, then we do detailed evaluation for that domain.
Yeah, I completely agree with both Sharda and Akhil. We cannot do CGAs in all our patients. We will not finish our clinics for the next month. So I think a screening is good. The problem again with the screenings, and it was pointed out by both Sharda initially, is that 98% of our older patients are vulnerable. So till we identify better cutoffs in our patients, the available screening tools are not great. but I agree that maybe screening is the way to go. I agree with that. So, okay. So as Sharda said, and as Akhil pointed out, we are all busy clinicians. We cannot do a CGA in all our patients. So I'll ask the geriatricians first, Abhijit, and then I'll ask one of the oncs. Assuming I cannot do a CGA, what do you think is the bare minimum I can do in a busy clinic to kind of compensate for that?
So the bare minimum, G8, I feel is good, but I felt West 13 was much better in finding vulnerable or fail population. So at least that, and then if they were having positive in that, then they can go.
Okay, I'll take it one step further. Assuming the screening is positive, I still can't do a CGA because I have so many patients. Then what?
Yeah.
Is there anything I can pick and choose in the Indian population where you feel this has to be done?
Yeah, the bare minimum would include nutrition, the physical function, maybe a chair stand or a tug, which can be done within a few seconds. These two are, I feel, are very important.
I agree. I agree on the nutrition for sure, and the functions. In an ideal world, we should be doing it for everyone, but the nutrition and functions is something that we might miss in our clinic. So I agree with that. Comorbidities, and I think Dr. Sharda in her lecture pointed out that it's done by all of us. So that is something that likely we will not miss. So maybe comorbidities, functions, and nutrition. Yeah, agreed. So there's some
one thing like ACCI and IADL or CAT index and other things that what we are doing in our clinic, we are just have a pilot project of 75 plus. So where the patients are segregated, that patient should go to geriatrician. I have all provided the IADL and ADL to at the segregation point already. Patient come to me after filling those forms to me. So we can do this because ACCI is easily understandable. Patient can comment yes or no. Yes, and other parameters, IADL, ADL, history of fall. These 4-5 parameters, if the patient is waiting outside the OPD, can be done. And lastly, CAR, it can be, or even other than lab parameters, the CARG can also be given to the patient where we can write easily. And even the lab parameters, only the GFR is the criteria where the clinician is needed, and that can be done via nurse also. So these are the parameters. So what need to be done, the oncologist or the clinician which is sitting inside just has to compile all these data, and that can be done in 3 to 5 months.
I agree, and I think that alludes somewhat to what Dr. Abhijit had said on intrinsic capacity. We need to find things that are short, and what you said goes with that. Maybe do 3 to 4 things of the 3 to 4 important things, and then go with that, and that would help. Agreed. So the same patient, some more info. Beyond what I had provided initially, his glycosylated HbA is 7. His CAD, EF is 40%. He has early neuropathy. He needs to get up twice at night because he has urinary frequency. He has some knee pain as well, and he has a host of medicines. I mean, this is not 1 or 2, this is around 10, and this is not abnormal, right? This is something we see almost all our patients take at least 3 to 4 medicines. So with this additional history, I mean, I'll start with Sharath here. You saw the number of medicines there, right?
Yes.
Now it's a no-brainer that this is polypharmacy, right?
Yes.
I mean, some people say 4, some people say 5, but this is like 10. So your definitions on polypharmacy as to how they apply in the Indian setup, and what do you suggest is the best practice for identifying PIMS?
Yes. So for identifying polypharmacy, I mean, as you said, guidelines differ for defining polypharmacy. Many would define that more than 5 medications would be termed polypharmacy. But if we see patients with renal disease, the average number of medications will be 8. So the definitions vary, but for the Indian setup, with the number of complementary medicines which they are taking and everything, if we include, then the average can be more than 5. So I think that should be, I mean, actually considered for Indian setup. And I mean, these medications are very much important because they'll have multiple comorbidities as well as many adverse events also. So drugs which are given to treat those adverse events also should be considered so that we don't miss any medications which could cause any side effects for those patients.
I agree on that. And I've just put 5 of the criteria that can be used for identifying inappropriate medicines. You have extensively worked on this, and so what do you think is the easiest to use in a daily practice? I'm sure, I personally think that I think the Priscus is very nice, but you can't use it daily. So your thoughts?
Yes, sir. According to the, study which we did in this scales, so the easier one, as you said, Priscus will be easier, but with the practice which we see, there are multiple drugs as we see in this patient. So to identify all those drugs, we need a good, criteria or a scale like Beers or EU7 to predict everything, so that we don't miss any potential inappropriate medication. But using all these scales in the
No,
daily
no,
clinical
not all,
practice
not all.
is
One.
difficult. Yes.
One. So I think, most people would agree that beers people are aware of. So, it covers most things.
Most.
Another thing which I think Dr. Sharath highlighted is the alternative medicines is something that's not always picked up in the West. And, Ayurvedic and homeopathic medicines, lack or presence of efficacy is something that is unique to our population, and that we should keep in mind. I agree. Yep. So some more info. We calculated his creatinine clearance and it was 45. So the question here is, it's around 40 to 45. I'll go back to the oncologist and I'll start with Sharda. Would you be happy with this assessment saying it's 40 to 45 and I'm good to start treatment? Or, would you use an alternative route, or would you do a DTPA? Sharda, can you hear me?
I do not routinely use a DTPA renogram, though I used to use it in my residency time. Somehow after coming to practice this thing, I do not routinely use a DTPA renogram. We use creatinine clearance, and creatinine clearance estimated by EGFR is the usual way we estimate creatinine clearance, or a Cockcroft-Gault formula. I know that it is not a perfect method, but what I follow is if his creatinine is impaired, I usually immediately refer to a nephrologist, since we have that facility here. I refer to a nephrologist and get all the medications checked and modified for renal doses, because I believe that it is beyond my purview to sit and modify antihypertensives, antidiabetics for the creatinine clearance calculated. So I immediately refer for an expert opinion. But for my part, for chemotherapy, I feel EGFR is or Cockcroft-Gault is currently okay.
Fair point. Anita, what do you think? I mean, we're running a study, of course, but what do you think? She says, okay, I know that DTPA may not be done, but this patient is 45 kilos. His creatinine clearance is 44. Would you want to do something more?
Definitely, your DTPA scan, in my view, will give a fair idea about the functioning of both the kidneys. And if there is any blockage also anywhere, we can make out by the DTPA, which will help us in identifying any problems with the system.
So, I mean, I agree with Dr. Sharda that we can't modify all the medicines which are non-oncology. We don't have the bandwidth for that. That I agree. Considering the cost of a GFR in our hospital, at least, is not much, I would try and do a GFR. It's actually for even our general patients, it's very less. But I get your point, Sharda. I mean, may not be possible in all centers. Akhil, you want to say something?
Yeah. So we are also routinely using GFR in our setting whenever we find the two conditions. One, creat is abnormally low. For example, we see a lot of patients with body weight of 40 kg, creatinine of 0.35. GFR coming to be 140, 150. It will definitely miscalculate the doses. One is that condition. Second is this borderline case where the GFR is between 40 to 55, where we know plasma sampling GFR will give a better dose of the carboplatin.
I mean, and this is well known. I mean, this is just one of the oldest data sets with this, that almost every drug will need to be modified if you have a poorer GFR on a DTPA. And, in a population which is already receiving so many medicines, they will need that much more modifications of drugs if their clearance is poor. So if I agree that if we can do, we should do a DTPA is what I feel. Right, some more information, and so I said the weight is 48. He had a weight loss of 8 kgs in 4 to 5 months. His BMI is 19, BSA is 45, and his MNA is 20. So next question to you, Sridhar, is, he's definitely at risk of undernutrition. Anything less than 23.5 on the MNA means you have a problem. So what are your thoughts on the MNA and, the questions that I have here?
So yes, the MNA is a good tool, but the issue is there are 18 points. Takes around maybe 12 to 15 minutes if you're actually trying to explain everything to the patient and
not happening.
Exactly. so basically using the MNA screening is good in a busy practice, and maybe doing the MNA in toto in patients who are, on screening found to be, at risk of malnutrition would be good. Again, what to do next for him? So usually we have a good nutrition clinic, at least in our setup, and it requires a formal nutritional consult, requires a proper dietary chart of what the caloric intake is and how we can improve. The issue with these patients is they, if all of a sudden we increase their nutritional intake, they are at risk of refeeding. So that is something that we should always look out for. So yeah, it requires a formal evaluation of dietary intake and an appropriate, supplementation of, all macro and micronutrients, because they are at risk of both. Again, for elderly patients requiring admission and TPN. Now, TPN has its own issues because, there are two types, peripheral and central. So peripheral TPN, you cannot give for long periods. Again, risk of thrombophlebitis, patient having a lot of nutritional imbalance, especially this patient, you're having a lot of comorbidities. You have an EF that is less, so you don't want to fluid overload that patient. So these issues will always come with TPN. I often feel that TPN is overused. And
okay, just as an add-on to that. So as a proportion in elderly patients, how many do you, in your estimation, require TPN out of 10?
Out of 10, maybe I'd say 1 or 2 tops.
Okay. Yeah. Okay, fair enough.
Yeah.
Okay.
So not all of them. Okay. So lastly, to facilitate nutritional optimization, now something that we do not look out for is how comfortable the patient is with the kind of nutrition that we offer. We often do not ask for history of difficulty swallowing, any loss of gag, dentition, all of these issues which are very common in the geriatric population. Again, we often switch to putting tubes which are aesthetically not pleasing for the patient, so automatically reduces intake. So, in those situations where patients are more comfortable, a PEG would be maybe better because it's a bigger tube. Feeding is always better. Nutritional optimization is also better. In situations where stents can be offered, I think a stent would be the right solution because they're able to take orally, so their intake automatically improves. So, we have to look at all of those parameters before we're able to take a decision.
Dr. Sharda, to add on to that point, do you have access to a nutritionist at your place, a proper dietitian?
We do have a dietitian service, but unfortunately our cancer center is quite, it's a separate block. So often when we refer our patients there, they find it very difficult to attend and get back to us. So initially I used to refer a lot of patients. Then I found that it leads to a lot of roaming around and a lot of extra effort for the patient. So now I do it for head and neck, I do it for selected patients, but not for...
yeah, I think that's a practical problem you brought out very well, that we want to do stuff, but if the patient gets lost in the process, you're achieving zilch. I agree with you. Yeah, Sridhar, please.
So there is also a dearth of, trained nutritionists. So luckily for us, we've had nutritionists who've been in the institute for really long. So luckily, again, this year onwards, we're starting a fellowship in onconutrition. So again, maybe that will also help to, help with this situation.
Fair enough. Fair enough. So till
excuse
now,
me,
based on,
to add to that, we used to have a dietitian who used to do rounds with us and who used to be very actively involved. But post-COVID, all dietitians are now working only at the
When in doubt, blame COVID. I agree. Yeah, Anita.
Which is why I think the geriatric assessment is absolutely essential, because we have dental health also as one of the
Yeah.
factors in it.
Yeah. I mean, we have quite an extensive assessment, which is why we take 50 to 55 minutes
Yeah,
compared
we
to
do take a
25 minutes in the West. And that 50 to 55
It is
minutes
after the patient
yes.
has filled the forms.
Yeah.
If
And
they
this
have
is
not,
this
it
is
is going to
after
long.
Ratan has eased the process immensely. After that, it's 50 minutes. So I completely do not agree with the 25 minutes the Westerners do it. It's a different population.
It's also about understanding the
Yeah.
forms, which is a big hassle,
Yeah.
because once they come inside the clinic, then they start asking questions.
Yeah.
And they have answered questions wrongly
Yeah,
mostly.
yeah. And this is also to do with the fact that we have to start from scratch in India in the elderly population. We don't have data, so yeah, it's a time consuming process. Yeah. So as of now, this patient, we know that they have multiple comorbidities. There's a borderline GFR, BPH, undernourishment, and needs modification of cancer. That's what we've identified. So coming to Ratan, who's already prepared a list of things he has to say. So, communication even for a physician patient in a language, and this was again highlighted by Sharda when she said that an oncologist needs to know 3 languages to communicate in a busy clinical practice. So what are the things that you face? Because if you are not able to do your things properly, we will take double the time. So, just let us know what you face.
So I prefer to speak in Hindi because all the assessment, the tools are there are in English. तो क्या होता है कि जो इंग्लिश में जो एक्चुअल है वो हम हिंदी में ट्रांसलेट करने के लिए बड़ा डिफिकल्ट है, क्योंकि एज इट इज नहीं होता. तो हमें उसका एसेंस समझ के वही चीज हमें पेशेंट को ट्रांसफर करना पड़ता है. वो सेम टाइम बड़ा डिफिकल्ट होता है. तो इस वजह से वो फॉर्म फिलिंग जो प्रोसेस है वो काफी लेंदी हो जाता है. अच्छा, तो इसके लिए हम हम जो टूल्स है वो हमें अलग अलग लैंग्वेजेस में ट्रांसलेट करते हैं और इजी टू रीड करते हैं पेशेंट के लिए. जैसे बस लिखा जाता है कि आपको ये चीज उठाने में तकलीफ होती है क्या, तो इंग्लिश में लिखा है कि याद नहीं आ रहा.
Yeah, can you lift 4 kgs or 10 pounds of weight?
तो इस मोर अगर क्योंकि अगर पेशेंट तो इलिटरेट रहता है, हमारे पास जो भी मोस्ट ऑफ जो रूरल एरिया से पेशेंट आते हैं वो इलिटरेट रहते हैं, लेकिन अपने काम में बड़े स्ट्रांग रहते हैं, लेकिन उनको वर्बली वो काफी स्ट्रांग रहते हैं. हम बोल के उनको सुना सकते हैं तो उनको समझ में आ जाता है, उन्हें पढ़ा हुआ समझ में नहीं आता. तो हम वो मोस्ट ऑफ कोशिश करते हैं कि हमारा जो लिटरेचर है वो ज्यादा से ज्यादा लैंग्वेजेस में ट्रांसलेटेड हो और एक्चुअल जो एसेंस है क्वेश्चन का वो पेशेंट तक पहुंच सके. जैसे मैंने एक क्वेश्चन बंगाली अगर मैं क्वेश्चन पढ़ता हूं कि जैसे हिंदी में लिखा है कि पिछले सप्ताह में आपने ज्यादातर अच्छी बातें सोची, ये हमने हिंदी में है. तो कभी कभी क्या होता है, जो एक्चुअल ट्रांसलेटर है वो चीज नहीं बोलता जो हम पूछना चाहते हैं. वो जैसे बंगाली है ट्रांसलेटर, वो बोलेगा तुम ही सब समय भालो चिंता करची. नहीं, हमने ये नहीं पूछा है, हमने ये पूछा है कि पिछले सप्ताह में आपने अच्छी बातें सोची कि नहीं सोची. लेकिन उसने क्या कहा कि आप हर समय अच्छी बातें सोचते हो कि नहीं सोचते हो. तो टोटली वो पूरा क्वेश्चन चेंज हो जाता है. तो हमें काफी चीजें समझ के उनको समझाना पड़ता है, पेशेंट और रिलेटिव के बीच में भी वो चीजें समझाना पड़ता है.
So that's a very important point, because not all the scales have a translation in vernacular. Even if they do, the patient may not be able to read it, even though he can speak the language. So I think the point that he raised was that the essence should be conveyed rather than the actual words. So I agree with that.
एंड नेक्स्ट ऑफ ऑल कि हमें अपॉइंटमेंट्स के लिए काफी दिक्कत होती है कि अपॉइंटमेंट्स लेने के लिए कोई बंदा आता है तो पूछता है ये सर 15 मिनट में खत्म हो जाएगा. मतलब क्या ये भेलपूरी बना रहे क्या जो 15 मिनट में खत्म हो जाएगा. सो और दूसरा सवाल ये आता है कि क्यों करना है असेसमेंट. तो हमें समझाना पड़ता है कि भाई कि आपके जो पेशेंट है वो काफी एल्डरली हो गए हैं तो उनको ये करना जरूरी है. तो जरूरी है किस तरीके से समझाते हैं हम, इस तरीके से समझाते हैं कि आपका जब बच्चा बीमार होता है तो क्या आप जो क्रोसिन की गोली खा रहे हैं वही क्रोसिन की गोली बच्चे को देते हैं क्या? तो ही सेड नो, वो तोड़ के देते हैं। तो इसे डोज मॉडिफिकेशन कहते हैं। तो ये एल्डरली में कैसे कर सकते हैं, ये समझने के लिए ही असेसमेंट किया जा रहा है। तो प्लीज ये करना जरूरी है, तो प्लीज आप कीजिए। अगर ऐसा कहते हैं तो ही कोई
Agreed. I mean, I think talking helps. And unfortunately, because we're also busy, the talking always doesn't happen. But, these kind of practical points, I think you have to do it and then only learn, or else you won't get it. And the thing about explaining it to the elderly patients, I think once you give them a couple of minutes, they do get the gist of it. Tarachand, you work in a predominantly Hindi-speaking population. Do you also face similar problems because you're now starting a geriatric program of sorts?
नो यूजुअली क्या होता है कि हम लोग रिकन्फर्म करते हैं। एक तो हमने उनको दिया हुआ है जो IADL एंड ADL का है, उसके बाद हम उसको रिकन्फर्म करते हैं, रिकन्फर्म। और
But you give it in English, is it?
नो, वी आर गिविंग इन हिंदी।
Yeah, makes sense. Correct.
Then we reconfirm, and we also sometimes find difficulty that what is written in Hindi. Then we also recheck from the English.
Yeah, I mean, it's an ongoing process.
And
that's
then
fine.
we ask from the English version.
Yeah.
That's why.
Yeah, it's like mixing gallbladders and urinary bladders, and this has happened in Tata. So, it's an ongoing process. I agree with you.
और एक चीज है कि खड़ी हिंदी भी काफी मुश्किल है। अगर आप ट्रांसलेट करते हो तो अगर एक्चुअल हिंदी वो काफी मुश्किल है। हम जो बोलते हैं हिंदी, वही हिंदी में एसेंस ट्रांसफर होना जरूरी है।
Spoken is different from written. I completely agree with that.
Yeah. So now I'm working in Varanasi, my hometown. So here the language is actually Bhojpuri, which is somewhat mixed version and which is a different text. So we need to explain, we need to have people who are able to explain the things not only in Hindi, but the local mixed version, the abbreviated changed version of it.
Agreed.
So
I completely agree that, and I think that again what Ratan said, the essence of what is written is to be converted, not necessarily that the exact verb, adverb, word, yeah, completely agree. And these are the things that we need to do, and no one else is going to do it for us. We need to do it, I guess.
We are doing everything is controversial, then we explain in Bhojpuri, or that is called that.
Okay, yeah, fair enough. What works. I mean, I think that's what works. Yeah.
Because we know that the Hindi is also difficult for us.
Yeah. So these are some of the short geriatric scales that were developed in India. This is by AIMS, and I think Sharda had shown this. There's actually a Hindi MMSE, which is tough, which is not very easy. And we know it because we've done it, and yeah, it's a tough one, but at least it's an improvement over the direct translation of the English MMSE for sure. It is slightly better. So then he was sent to the geriatric clinic, this patient, and this was his screening test. His TRST was 2, VES was 2, G8 was 11, TUG was 15. So my initial impression that he's PS1 with okay, we can take him up. He slowly started developing issues in every head we have assessed. So this is to Dr. Sarika. This patient has vertebral bone mets, even though he's asymptomatic. How would you, and his TUG is 15, IADL, ADL is okay, but bone mets, TUG 15. How would you approach him?
The patient does not have any symptoms.
Does not have any bony symptoms, yeah.
So first of all, I would like to assess the patient from my side. I really want to see whether he really has good strength in his lower limb. And also the second important thing is the balance issues. So you've talked about the TUG. TUG is 15. For the Indian elderly, it is 14.5. The cutoff is 14.5. So if the patient has balance issues, the patient is going to have an increased risk of fall. So I need to assess both these things. And also because the patient has a lot of comorbidities with respect to his PFTs and with his cardiac condition, I would like to also do a aerobic testing of the patient. Okay. So these three things are must when the patient will be assessed by me. So once if I find the patient has lower limb strength, which is very poor, then I'm going to start with the intervention for him. Okay. But that will be based on my assessment. If I feel that if I run an SPPB, that is a short physical performance battery, where I look at the 5 repetitions of chair stand test, and I feel the patient has weakness over there, then I will go for an in-depth assessment, okay, to chart the muscle power. If there is any domains which is affected, the muscle power is affected, then I'm going to start with intervention, that is exercises for them. And that will be under supervision. So one important thing when we do these exercises, we first ask them whether they will be able to come to us every day. If they are not coming, then we see to it that the patient takes a video of it so that they can do it at home. And usually we call them after 2 weeks. Okay, so this is what we usually begin with. And also if the patient has any aerobic reduction, then we also need to find out what is their artery reserves and all that. And based on that, we give them an intervention at home for walking. Because walking, everybody does, but nobody does at that targeted level, which is very important. Okay? So we usually do that and call the patient after 2 weeks.
Makes sense. I mean, I started sending a lot of patients, even, I just tell them to do the 5-sit thing. And if they can't do one, then, go for lower limb strengthening. It's an easy way, even if you don't do a full geriatric assessment to, get things. And patients actually feel better when you say, okay, we'll help you get up from the floor, something as simple as that. If they can improve, they feel better. So
Yeah.
I agree with you. Your thoughts on communicating these things with Indian patients? Is it easily understood by them? Do you think it is a something that is tough to explain?
So initially, the patient is very hesitant to talk. And to tell you the truth, our geriatric patients don't have anybody to listen to them.
Yeah.
So they really love to talk. So when they come to us, they have so much to talk. And the relatives are always talking to us saying, okay, this is happening, this is happening, this is happening. And then the patient is also talking. So it's a good thing because we can explain to them. And every time we ask them, how do you feel after doing the exercises? So many a times patients have said that, I'm eating better, I'm sleeping better, my fatigue has gone down. So these are few things which patients have given feedback to us. Where we lag or where we, feel that, the patient is not doing that well is when they take their first cycle of chemotherapy. And that is the time they actually crash. And we see that the patient themselves say that, I was doing so well till last week, and this week I really can't make it to the hospital. I mean, I can give you an example, a patient coming to the radiology department for radiation, but not coming up to my department for exercise because he's like, I'm so exhausted, because the primary aim of them is getting the treatment for the disease, not being physically fit. I think exercise is not that important in everybody's mind right now when the disease is at the higher end.
Yeah, I mean, I think it's quite a shock to the system, the disease and the treatment. It's just, everyone wishes we had easier answers. That the treatment is tough and the disease is tough. So a lot of patients actually, we underestimate fatigue. We do it as an evaluation in the clinic,
Yeah.
But as an oncologist, when I'm taking the OPD, fatigue, okay, it will go. So I agree with you on that.
So there is a form which we fill, that is the brief fatigue inventory. And like Ratan said, it is difficult for patient to understand how to fill it. Okay. And we talk about last week, severe, worst, and it's very difficult for the patient to understand what we are trying to say, because though it is in Hindi, Marathi and Bengali, they cannot understand. It's in that proper language which they really don't understand. And if you look at the ACSM guidelines, they have different guidelines for exercises for patients with fatigue. If they have specifically fatigue affection, how do you go about with the exercise protocol? If the patient has only physical function affected, then how do you go about it? So they have beautifully laid down all the interventions and how you go about it. But because we do not get that patients, and patients are not willing to come for that long, we fail to give that intervention.
I was going to come to the fatigue and exercise, but I think, you covered it. Yeah. So, Ratan.
So there is a more, for most of our patients, there is a more, the more issue is a financial issue. Because of the financial issue, they are not coming back again and again. Because everybody is doing their, if a child is a bread earning person and his father become ill, so the father doesn't want to go again and again hospital because the child have a financial burden on it.
Yeah, I completely agree. That's the $1 million thing, that in our country with our limited resources, follow-up is tough. I agree. So this, coming to the final parts of the psychosocial thing, and this is where Dr. Lekika comes in, and she mentioned it briefly, and I think Sharda had also mentioned it. Even now, if I say that I'm going to a psychologist, I'm not talking of a cancer patient. Forget that. I'm talking of a normal person. You're not going to disclose that you're going to a psychologist or psychiatrist. I'm pretty sure. And that's because of the taboo associated with it. And to tell that, okay, you have cancer, you need chemo, and then you are depressed as well, it's like a triple whammy. So, Dr. Anita, your thoughts, because I know this is something that, you're working on a manuscript also. Why? I mean, we're in the 21st century, but it's still a problem. Why?
I guess it's just a social construct surrounding going to a psychologist. Tu pagal hai kya? That is the usual
I
idea.
completely agree with that. That's the standard line.
तू तो पागल नहीं है, या तू ऐसे क्यों जाना क्यों चाहता है, वो कोई डॉक्टर कुछ भी बोलता है, तुझे कुछ नहीं है, तू मत जा. That is, and because they don't want the people around them to know that their particular relative has got a psychological problem, so they don't want anybody to know, basically. So, and it is not just in the lower socioeconomic status; it is there in the higher socioeconomic status as well. Agree. So the taboo is from top to bottom. It's not just the bottom strata of patients.
Agreed. Yeah, Kirtan.
Yeah. So what I find, there are two age groups, which are most vulnerable to peer pressure and something like that. One is adolescent and second is this older age. So these two age groups are actually somewhat similar, and the social aspects, psychosocial aspects are actually matching. So
okay, that's interesting. I never thought of it that way, but I'll ask Dr. Lekika. Dr. Lekika, I mean, we all agree that it's accepted that it's a taboo. Now, this patient, if he was in a non-geriatric setup, no one would have asked him about his history of, whether he's even anxious about treatment. We'll tell him, okay, this is the disease, this is the cancer, be nice, this is the treatment. I'm not going to, do a GAD, GDS, but we did it for this person, and he's obviously very anxious. His GAD is 11, right? So my questions to you are, how would you interpret this psychological profile? And again, we are in a busy hospital. What would you do? Can you see the screen?
Yes. So you are talking about the case, right? Or that non-oncology, non-geriatric oncology patient?
No, the same patient who has a GAD of 11. Yeah.
So very important actually, patient as patient is 60-year-olds or elderly and having metastatic lung cancer. So in metastatic, that many of the physical factors are been involved, and many physical and that psychological aspects to be evaluated. For example, if patient is having lung cancer, so maybe he some amount of dyspnea or breathing difficulty, pain, and sleep disturbances, and all these factors contributed to psychological distress. So first of all, that when patient comes to us, so important thing that we need to establish rapport, because when as soon as patient comes, that he looks very anxious, or sometimes that he feels that why he has been referred to psycho-oncology. But in geriatric population, these things I have not seen majorly. But yeah, for other, adolescent, that this is common, that they don't appreciate that psychological, referral. But for geriatric patient also, that we need to establish rapport, and that we take detailed evaluation about their, presenting complaint or their past history of psychiatric illness, the history of substance uses, and that family setup.
How often do you see you mentioned substance abuse. How often do you see it in elderly patients? And when I say substances use, I mean I'm beyond tobacco and smoking. Is it common?
Actually, in geriatric patients, that we have not majorly seen in most of the patients, but yeah, if there is mostly that history of smoking. If patient is having a head and neck cancer diagnosis, so we need to focus that thing also, because this may interfere the treatment. So along with psychological assessment and intervention, that we need to refer the patient to de-addiction setup also, This is very important. At the same time, that cancer treatment and that de-addiction goes together. Yeah.
It's very tough to tell a 70-year-old man who's been smoking for 50 years to stop smoking. He generally laughs. And I've had this experience that, I mean, I've lived 50 years like this. I have a stage 4 cancer and you're telling me to stop smoking. Generally,
Yeah.
they have that look which says, take a hike, so,
But other
but I
thing
agree
that,
with you. It should be done.
yeah, actually, the patient, it is not possible for a patient, but that is your evaluation and practice said that we need to evaluate every way and intervene the patient every way. And other things that apart from psychopharmacological intervention specifically for addiction, that there is that psychological intervention for patient which helps to improve the quality of life during their cancer treatment and afterwards. So that is equally important. So in our setup, first that we evaluate that multiple factors, for example, anxiety, depression, that psychosocial stressors which may hinder their treatment and coping, and we need to evaluate, and accordingly that psychological intervention uh, is to be facilitate for patient as well as caregiver.
Yeah, yeah. I think caregiver burden is something that we are slowly
Yes.
recognizing. And in the West, it's well documented. They have
Yes.
coping strategies for that. In India, I think we terribly under evaluated. Yeah, Anita, tell me.
Just today, we had a patient whose relative came to us and told us that he is during chemotherapy, he will take chemotherapy and go back and start smoking.
Oh yeah, that's very common,
So it is
unfortunately.
very common. That's
Yeah, yeah.
I would like to throw light on this point. May I?
Yeah, please go ahead.
Yeah. So recently that I have one patient, I have patient and that caregiver, patient is elderly and that caregiver is quite young. And then she has a lot of ventilation of emotion. So these things should be picked up by the psychotherapist, and that they need regular evaluation and they need regular assessment. They need regular intervention, so that that caregiver will be better helped in the uh, in the treatment period of a patient. So that young girl, that she was she is the only person in the family that she knows about the prognosis, and patient is metal progressive disease, and she have not told anyone, she didn't disclose the truth, and that she was dealing and struggling and conflicting with the conspiracy of silence. So that need to be evaluated for caregiver also, to that slow down their burden. So that is very important.
I agree. I mean, this whole circuitous route that we have in India that tell the caregiver, not the patient. If this was the West, we would all be sued. You cannot treat a patient without telling them, but that's the way it is. I mean, so yeah, thank you, Dr. Lekika. I completely agree with what you said. So our final summation after 30 minutes is this person has multiple deficits that need to be evaluated. And one of the slides, I think, and this is a paper in JCO, I know the CGA takes time, but it seems to be worth it, at least in patients who are even slightly vulnerable. So, I think we covered CGA, CAG, and, Dr. Tarachand had covered that quite extensively. We now have Indian data on the CAG, and we have Indian data on the crash as well from Delhi. 3-4 centers in Delhi collaborated to show that the crash score is valid in Indian patients. Slightly longer to do, but I mean, I would use the CAG. I use it now routinely in all my patients above at least 60, 65, and it's immensely helpful. For those who feel that, I'm doing all this, I'm taking an hour, what are the outcomes? I suggest all of you read these 3 papers. Toxicity reductions are anywhere between 10 to 20% with a CAG, and you can easily dose reduce. Now, how you dose reduce is a different question, and that's clinical acumen. We are running a study to answer. But I mean, the take home that I want is that a geriatric assessment, even if you can't do it in all, try, pick it up and do it in as many as possible. It definitely helps. And now there's data to say that they have lesser side effects. It may be only 10 or 20%, but it's important for this vulnerable group of patients. With that, thank you all the panelists. I hope you learned as
Dr.
much as I
Anant,
did. Thank you
Dr.
so
Anant.
much. Yeah.
One
Yeah,
thing
just
was,
1 minute.
Sure.
Yeah.
Yeah.
Yeah. Actually, I would like to tell you that the case of lung cancer and that depression is quite prevalent in lung cancer, and that should be treated either with psychological, intervention and psychopharmacological, and that should be evaluated regularly on review basis. So that is very important, and that is left to be told. So that I
And
summarized.
then
Yeah.
I agree with you. And then we need to look at the drug interactions of those drugs.
Yes. Yes.
And,
Yes.
you know, yeah, I agree with you. Yeah. Yeah, Dr. Tarachand.
boss,
Last comment
boss,
is always
the-
Dr. Tarachand.
boss, there was one very weird opinion from an oncologist, senior oncologist, that the patient is 70 or other and patient is having terminal cancer like head and neck stage 4, esophagus, liver or gallbladder like cancer, and patient is a smoker. So I think smoking is his quality of life. This was a very weird opinion from, and sometimes I agree with him.
So I have personally speaking, and I could be wrong, I have a very strong anti-smoking thing. I absolutely detest it. So, but there are so many patients who've literally laughed in my face when I tell them stop smoking at 70 that, you know, I tell them nicely, I tell them a little not so nicely, and then I leave it at that. It is not in our purview to tell a 70-year-old man, boss, change your life. Not happening. So that's what I think. But and he might agree with you, it's not good. He's probably going to go half a kilometer away, and you know what he's going to do. So yeah, it's very tough. I agree with you. Yeah. Thank you, everyone. Thank you so much.
Thank you.
Thank you.